Live.
Ma'am, we are on live and we are starting session, ma'am.
Okay.
Very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is PCOS and gut dysbiosis. I'd like to welcome all the participants who has joined here today evening, and I also like to introduce our invited speaker for the day, Dr. Surekha Vinay, ma'am. Madam has done her MBBS, DGO, and DNB OBGYN. Madam has done her MBBS from Kurnool Medical College, DGO from SV Medical College, Tirupati, and DNB from Sanchira Medical College. Madam is currently the practicing obstetrician and gynecologist since 15 years, working as a private consultant in Gauri Gopal Hospital and St. Teresa's Hospital and her own Gibson Clinic, Kurnool. Madam is an infertility specialist and laparoscopic specialist as well. Madam's special interest is PCOS, weight loss management, high-risk pregnancy, and menopause. So with this short introduction, I welcome you, ma'am. I'm handing the session to you for your presentation, ma'am. Welcome, ma'am.
Thank you for your nice words. Let us start this session. Today's topic is PCOS and gut dysbiosis. And apart from dysbiosis, it has some slides regarding infertility, treatment of infertility, and some drugs. Let's start.
Ma'am, click on the slide once and down arrow, ma'am. Yes, ma'am.
Yeah. Polycystic ovary syndrome affects about 5 to 20%. It's a heterogeneous condition, may present with reproductive, endocrine, metabolic, and psychosocial symptoms. PCOS remains underdiagnosed with significant delay to diagnosis. It's a complex disorder and it has an impact on quality of life. It requires timely diagnosis, screening for complications, and management strategies. Coming to epidemiology, one of the most common endocrine disorders affecting women of reproductive age, seen in 8 to 11% of reproductive age group women. Most common cause of anovulatory infertility in women. Anovulatory infertility, about 70 to 80% is seen in PCOS. Indians have among the highest prevalence rates in the world. It's around 41% in reproductive age. Coming to the pathophysiology of PCOS, if you look into the right side of the chart, the hypothalamus leading to abnormal GnRH pulsations, which acts on pituitary gland, releasing abnormal gonadotropin levels, increase the LH and FSH ratio, which in turn acts on ovary, causing ovulatory dysfunction. And this dysfunction leads to one is hyperandrogenism and follicular arrest. The results of follicular arrest are uterus with endometrial hyperplasia and anovulation and amenorrhea. And the follicular arrest leads to PCO morphology on ultrasound. And the hyperandrogenism due to ovulatory dysfunction, it's in turn stimulated by increased adrenal androgens and decreased sex hormone binding globulin levels in the liver. This hyperandrogenism affects the release of progesterone, which in turn leads to abnormal GnRH production. And the ovarian dysfunction is also caused by the pancreas with hyperinsulinemia, which is interchangeable along with insulin resistance. Insulin resistance of muscle and liver and adipocyte dysfunction and hyperinsulinemia, both regarding pancreas, they act on ovary, again leading to ovulatory dysfunction. The skin effects of hyperandrogenism, they are acne, hirsutism, acanthosis, nigrans. Diagnosis of PCOS. In 1990, according to NIH criteria, patient demonstrates both, that is clinical and or biochemical hyperandrogenism and oligo-ovulation and chronic anovulation. In 2003, the H-ray or ASRM Rotterdam criteria, 2 out of the 3 are necessary to make the diagnosis. One is oligo or chronic anovulation, clinical and or biochemical hyperandrogenism, and PCOS ovarian morphology on ultrasound. In 2006, AES criteria they demonstrate both, that is hirsutism and or hyperandrogenemia, oligoanovulation and or polycystic ovaries. There's a spectrum of PCOS from childhood to postmenopause. That is, it can be called as a disease from womb to tomb. It has its own effects at every stage of a woman's life. Coming to the phenotypes of PCOS, phenotype A, B, C, D. If you look into the phenotype A, all three are present: hyperandrogenism and hirsutism, ovulatory dysfunction, and polycystic ovarian morphology. Coming to the phenotype B, hyperandrogenism and hirsutism and ovulatory dysfunction are present, and no polycystic ovarian morphology on scanning. And coming to type C, only hyperandrogenism and hirsutism along with polycystic ovarian morphology is present. Here there is no ovulatory dysfunction. Coming to the phenotype D, there is no hyperandrogenism and hirsutism, but ovulatory dysfunction and polycystic ovarian morphology are present. Coming to the genetics and lifestyle, which are the main cause affecting the hormonal changes in PCOD, and these hormonal changes are exacerbated by obesity. If you look into the pathology, one is increased androgens and increased insulin. Both are interchangeable. One leads to another. Increased insulin leads to diabetic metabolic syndrome, which in turn has cardiovascular risk. And androgens and increased insulin, they act on ovarian follicles, anovulation with increased estrogens. All the three manifested by hirsutism, acne in the skin, menstrual disturbances and subfertility, and cardiovascular risk, and the psychosocial issues leading to body image, self-esteem, depression, and anxiety. So it is a multifactorial disease. The epidemiological link. PCOD increases the risk of gestational diabetes by more than 200%. Insulin resistance is present in 65 to 80% of PCOD cases, and 60% of GDM patients develop type 2 diabetes mellitus, and PCOD increases the risk of type 2 diabetes by 1600%. So there is a lot of disease causing in PCOD regarding diabetes. Coming to clinical features, the most important three features: one is gynecological with irregular menses and infertility, and the second metabolic, that is insulin resistance, obesity, increased chances of type 2 diabetes and acanthosis nigrans, and the third is androgenic, alopecia, hirsutism, acne. These are all intertwined. You cannot separate one from the other regarding the clinical features. Factors that predict live birth in PCOS infertility therapy. One is younger age, lower BMI, shorter duration of infertility therapy, less severe oligomenorrhea, lower androgen level. PCOS and fertility. The first line of treatment, that is improvement in lifestyle. In obese patients, weight loss, changes in diet and physical activity recommended. Weight loss decreases serum insulin androgen levels, reduces the risk of glucose intolerance and type 2 diabetes mellitus. Pharmacological interventions are required in the presence of insulin resistance or glucose intolerance or dyslipidemia that persist after lifestyle modifications. Management of PCOS. International evidence-based guideline for the assessment and management of PCOS in 2018, that is guideline 1. It requires screening, diagnostic assessment, risk assessment, life stage and adolescence. Guideline 2, it includes prevalence, screening, diagnostic assessment and management of emotional well-being. And guideline 3 is entirely on lifestyle. Pharmacological treatment in PCOS for non-fertility indications. and guideline for screening, diagnostic evaluation, management of infertility. Lifestyle intervention, PCOS, prevalence and BMI. If you look into the chart, the higher the BMI, the prevalence of PCOS is increased. Coming to the PCOS and excess weight gain, it has adverse effects regarding worsened psychological function, worsened cardiovascular disease and diabetes mellitus risk factors, increased androgen activity, increased insulin resistance, ovulatory dysfunction, infertility, oocyte embryo, and reduced ART success. All these are impacted by PCOS with excess weight gain. Obesity affects spontaneous pregnancy chances in subfertile ovulatory women. BMI more than 29 associated with reduced success of ongoing pregnancy. 4% lower pregnancy rate per kg per square meter BMI increase. Lifestyle intervention, first line therapy, fertility, reproductive, metabolic. Healthy lifestyle for excess weight gain. Prevention is important for all women with PCOS regardless of weight. Overweight or obese. Aim for 5 to 10% weight loss in 6 months. Monitor and support with achievable goals. Assess weight respectfully in all at least 6 to 12 monthly intervals. Lifestyle intervention. Coming to the recommendations by CCR, that is clinical consensus recommendation, healthy lifestyle behaviors encompassing healthy eating and regular physical activity should be recommended in all those with PCOS to achieve and or maintain healthy weight and to optimize hormonal outcomes, general health, and quality of life across the life course. And coming to EBR, that is evidence-based recommendations, lifestyle intervention, preferably multi-component including diet, exercise, and behavioral strategies should be recommended in all those with PCOS and excess weight for reductions in weight, central obesity, and insulin resistance. And achievable goals such as 5 to 10% weight loss in those with excess weight yield significant clinical improvements and is considered successful weight reduction within 6 months. Ongoing assessment and monitoring is important during weight loss and maintenance in all women with PCOS. Coming to CPP, that is SMART, specific, measurable, achievable, realistic, and timely goal setting, and self-monitoring can enable achievement of realistic lifestyle goals. Lifestyle intervention of diet. A variety of balanced dietary approaches could be recommended to reduce dietary energy intake and induce weight loss in women with PCOS and overweight and obesity as per general population recommendations. And according to CCR, general healthy eating principles should be followed for all women with PCOS across the life course as per general population recommendation. And according to CPP, tailoring of dietary changes to food preferences, allowing for a flexible and individual approach to reducing energy intake and avoiding unduly restrictive and nutritionally unbalanced diets are important as per general population recommendations. Coming to CCR, lifestyle intervention of exercise, health professionals should encourage and advise the following for prevention of weight gain and maintenance of health. In adults from 18 to 64 years, a minimum of 150 minutes per week of moderate intensity physical activity or 75 minutes per week of vigorous intensities or an equivalent combination of both, including muscle strengthening activities on 2 consecutive days in a week. In adolescents, at least 60 minutes of moderate to vigorous intensity physical activity per day, including those that strengthen muscle and bone at least 3 times weekly. Activity be performed in at least 10-minute bouts or around 1,000 steps, aiming to achieve at least 30 minutes daily on most days. And CCR recommendation, health professionals should encourage and advise the following for modest weight loss, prevention of weight regain, and greater health benefits. A minimum of 250 minutes per week of moderate intensity activities or 150 minutes per week of vigorous intensity, or an equivalent combination of both, and muscle strengthening activities involving major muscle groups, or 2 non-consecutive days per week. Minimize the sedentary, screen, or sitting time. And when we look into bariatric surgery for weight management, bariatric surgery should be considered in experimental therapy in PCOS for the purpose of having healthy baby, with risk to benefit ratios currently too uncertain to advocate this as fertility therapy. If this surgery is to be prescribed, the following need to be considered. One is comparative cost, the need for a structured weight management program involving diet, physical activity, and interventions to improve psychological, musculoskeletal, and cardiovascular health to continue post-operatively. And coming to the perinatal risks, such as small for gestational age, premature delivery, possibly increased infant mortality, potential benefits such as reduced incidence of large for gestational age fetus and gestational diabetes, and recommendations for pregnancy avoidance during periods of rapid weight loss and for at least 12 months after bariatric surgery with appropriate contraception. If pregnancy occurs, we need to monitor pre- and post-operative nutritional deficiencies and monitoring of fetal growth during pregnancy. Management of infertility. Assessment and treatment of infertility. First-line non-pharmacological management for infertility is only lifestyle intervention. And the first-line pharmacological management is, one is letrozole. Consider letrozole as first-line therapy. Then comes clomiphene citrate, then clomiphene citrate plus metformin combination, and plain metformin, and the last gonadotropins. And the second-line pharmacological surgical management is, one is gonadotropins and laparoscopic ovarian surgery. And the third-line management could be other appropriate intervention, including IVF. Letrozole recommendations. Letrozole should be considered first-line pharmacological treatment for ovulation induction in women with PCOS with anovulatory infertility and no other infertility factors to improve ovulation, pregnancy, and live birth rates. Where letrozole is not available or use is not permitted or cost is prohibitive, health professionals can use other ovulation induction agents. Health professionals and women need to be aware that the risk of multiple pregnancy appears to be less with letrozole compared to clomiphene citrate. Dosage, how to use letrozole. Dosage is 2.5 to 5 milligrams per day for 5 days. You can start from day 1 to day 5. And letrozole step-up protocol, that is 1 to 10 days, 1 to 10 days, 2.5 to 5 mg per day. And the ultrasound needs to be done on 11th and 13th day for ovulation. Dose, how to use clomiphene citrate. Dose is 50 milligrams per day for 5 days. It can be started from day 1 or day 2, consequently for 5 days till 5 to 10th day or 2 to 9th day. And same on 11th and 13th day, we need to do ultrasound. If there is no response for 50 milligrams per day ovulation, the dose can be increased to 100. If no ovulation, it can be increased to 150 milligrams. If there is ovulation, 2 to 3 cycles with same dose and no pregnancy, then we need to look into suboptimal endometrium, that is less than 77 millimeters might be the cause for no pregnancy, or hypogonadotrophic hypogonadism. And both of these conditions need treatment with injectable gonadotropins with ovulation and no pregnancy. Clomiphene citrate plus metformin. What does the evidence say? Clomiphene citrate could be used alone in women with PCOS with anovulatory infertility and no other infertility factors to improve ovulation and pregnancy rates. Metformin could be used alone in women with PCOS with anovulatory infertility and no other infertility factors to improve ovulation, pregnancy, and live birth rates. Although women should be informed that there are more effective ovulation induction agents. If metformin is being used for ovulation induction in women with PCOS who are obese, that is BMI more than 30 per square meter with anovulatory infertility and no other infertility factors, clomiphene citrate could be added to improve ovulation, pregnancy, and live birth rates. Clomiphene citrate could be combined with metformin rather than persisting with clomiphene citrate alone in women with PCOS who are clomiphene citrate resistant with anovulatory infertility and no other infertility factors to improve ovulation and pregnancy rates. Concepts what metformin. Where metformin is prescribed, the following need to be considered. Adverse effects, including gastrointestinal side effects that are generally dose dependent and self-limiting, need to be the subject of individualized discussion. Starting at a low dose with 500 milligram increments 1 to 2 weekly and extended release preparations may minimize side effects. Metformin use appears safe long-term based on use in other populations. However, ongoing requirement needs to be considered and use may be associated with low vitamin B12 levels. Use is generally off-label and health professionals need to inform women and discuss the evidence, possible concerns and side effects of metformin. Coming to gonadotrophins, the recommendations are gonadotrophins could be used as second-line pharmacological agents in women with PCOS who have failed the first line of oral ovulation induction therapy and are anovulatory and infertile with no other infertility factors. Gonadotrophins be considered as the presence of ultrasound monitoring following multiple pregnancy in women with PCOS with anovulatory infertility and no other infertility factors. Gonadotrophins were available in preference to clomiphene citrate combined with metformin therapy for ovulation induction. In women with PCOS with anovulatory infertility, clomiphene citrate resistance, and no other infertility to improve ovulation, pregnancy, and live birth. Gonadotrophin with the
Aparna ma'am, sorry for the disturbance, ma'am. Please be on mute, ma'am. Aparna ma'am.
Used rather than gonadotrophin alone in women with PCOS with anovulatory infertility, clomiphene citrate resistance, and no other infertility factors to improve ovulation, pregnancy, and live birth rates. Either gonadotrophins or laparoscopic ovarian surgery could be used in women with PCOS with anovulatory infertility, clomiphene citrate resistance, and no other infertility factors following counseling on benefits and risks of each therapy. Gonadotrophin therapy is suitable for improving infertility in women with PCOS in specialist care with close monitoring. Gonadotrophin therapy provides better per cycle and cumulative pregnancy and live birth rates compared with the use of oral anti-estrogens and or no therapy in anovulatory women with PCOS, and there is no evidence of teratogenicity. It is important to note that gonadotrophin therapy requires daily injections and the need for intensive monitoring with ultrasound, with a risk of multiple pregnancy and increased cost of medication compared with oral agents. Laparoscopic ovarian surgery. Laparoscopic ovarian surgery could be second-line therapy for women with PCOS who are clomiphene resistant with anovulatory infertility and no other infertility factors. Laparoscopic ovarian surgery could potentially be offered as first-line treatment if laparoscopy is indicated for another reason in women with PCOS with anovulatory infertility and no other infertility factors. Coming to laparoscopic ovarian surgery, this could be second-line therapy for women with PCOS who are clomiphene citrate resistant with anovulatory infertility and no other infertility factors. Laparoscopic ovarian surgery could potentially be offered as first-line treatment if laparoscopy is indicated for another reason in women with anovulatory infertility and no other infertility factors. Risk should be explained to all women with PCOS considering laparoscopic ovarian surgery. Where laparoscopic ovarian surgery is to be recommended, the following should be considered. One is comparative cost, expertise required for use in ovulation induction. Intraoperative and postoperative risks are higher in women who are overweight and obese. There may be a small associated risk of lower ovarian reserve or loss of ovarian function. Periadnexal adhesion formation may be an associated risk. Coming to the role of inositol in PCOS. Inositol and insulin signaling. If you look into the picture, the insulin receptor resides in the cell membrane. When its beta subunit is phosphorylated by insulin, insulin receptor substrates, that is IRSA, are activated. And P13K docks to IRS, which then leads to phosphorylation of phosphatidylinositol, eventuating in inulin action. Myoinositol increases insulin sensitivity by making more phosphatidylinositol available. Myoinositol and D-chiro-inositol deficiency in PCOS. If you look into the picture, both MI and DCI levels are very low in PCOS patients compared to the normal subjects. Meta-analysis of 9 randomized controlled trials involving 247 cases and 249 controls. There was significant decrease in fasting insulin, significant decreases in homeostasis model assessment, that is HOMA index, a trend of reduction of testosterone concentration by MI, a significant increase in serum SHBG observed within 24 weeks treatment. The trial sequential analysis of insulin meta-analysis illustrates a firm evidence of MI and beneficial effect of myoinositol in improving the metabolic profile of PCOS women, concomitantly reducing hyperandrogenism. So myoinositol reduces fasting insulin in PCOS. It reduces HOMA in PCOS. It reduces testosterone in PCOS. It reduces androstenedione, and inositol favors live birth rate in PCOS. So if you look into the study, there is increased incidence of live birth rate in PCOS than without treatment with inositol. So inositol favors live birth rate. Inositol pre-treatment to IVF also, there was a Cochrane library study, myoinositol versus placebo and standard treatment as pre-treatment to IVF. In women with PCOS, there was increased incidence of live birth rate. Inositol favors live births in ovulation induction. There was a comparison of 5 myoinositol versus an ovulation induction agent. In women with PCOS undergoing ovulation induction, inositols have a role in increasing the ovulation induction. Inositol favors clinical pregnancy versus metformin. There is a comparison of 4 myoinositol versus insulin sensitizing agent, that is metformin, in women with PCOS undergoing treatment. The outcome, there was one clinical pregnancy when myoinositol was used in the study. Inositols also favor clinical pregnancy as IVF pre-treatment. Better adverse event profile. Peculiarities of IVF in PCOS women when the first line fails. That is, the goal is pregnancy and the priority is safety. A meta-analysis of outcomes of conventional IVF in women with polycystic ovarian syndrome for number of oocytes per ovum pickup and for number of oocytes fertilized or chance of cancellation or for chance of live birth per started cycle or for chance of miscarriage per started cycle. Cumulative live birth rates after IVF in patients with polycystic ovaries phenotype matters. There was a cohort study of 567 patients for 5 years. The conclusions for hyperandrogenic PCOS phenotypes confer significantly clinical live birth rate compared to their normoandrogenic counterparts. These findings may imply the need for adapted counseling and tailored approach when treating PCOS patients with hyperandrogenism who require ART. Cumulative live birth rate after IVF in patients with polycystic ovaries phenotype matters. There is highest incidence in the phenotype D, that is no hyperandrogenism. And you can see the incidence 53.3 with PCOM plus ovarian dysfunction plus hyperandrogenism 25.8, and phenotype C is 27.8, and phenotype D, that where there is no hyperandrogenism, it is 48%. The more severe the PCOS phenotype, the lower the probability of clinical live birth rate. Influence of metabolic syndrome on female fertility and IVF outcomes in PCOS women. A secondary analysis of multicentric RCT, 1508 PCOS women live birth rate after fresh embryo transfer versus frozen embryo transfer. Conclusion: women with polycystic ovarian syndrome with metabolic syndrome have a negative impact from female fecundity, and this suggests an adverse effect on in vitro fertilization cycle stimulation characteristics and clinical outcomes. In vitro maturation. According to the recommendation, the term in vitro maturation treatment cycle is applied to the maturation in vitro of immature cumulus oocyte complexes collected from the antral follicles, encompassing both stimulated and unstimulated cycles, but without the use of a human gonadotropin trigger. In units with sufficient expertise, in vitro maturation could be offered to achieve pregnancy and live birth rates approaching those of standard IVF with or without ICSI treatment, without the risk of OHSS for women with PCOS, where an embryo is generated, then vitrified and thawed and transferred in a subsequent cycle. Ovarian stimulation for IVF in PCOS. A gonadotropin releasing hormone antagonist protocol is preferred in women with PCOS undergoing IVF with or without a ICSI cycle over a gonadotropin releasing hormone agonist long protocol to reduce the duration of stimulation, total gonadotropin dose, and incidence of OHSS. Human chorionic gonadotropins is best used at the lowest doses to trigger final oocyte maturation in women with PCOS undergoing an IVF with or without ICSI cycle to reduce the incidence of OHSS. Coming to the choice of FSH. Urinary or recombinant FSH can be used in women with PCOS undergoing controlled ovarian hyperstimulation for IVF with or without ICSI, with insufficient evidence to recommend specific follicular FSH preparation. Exogenous LH. Exogenous recombinant LH treatment should not be routinely used in combination with FSH therapy in women with PCOS undergoing controlled ovarian hyperstimulation for IVF with or without ICSI. Coming to adjunct metformin. EBR recommendation, that is adjunct metformin could be used before and or during follicular stimulating hormone ovarian stimulation in women with PCOS undergoing IVF with or without ICSI therapy with a GnRH agonist protocol to improve the clinical pregnancy rate and reduce the risk of OHSS. In a GnRH agonist protocol with adjunct metformin therapy in women with PCOS undergoing IVF with or without ICSI treatment, the following could be considered. Metformin commencement at the start of GnRH agonist treatment, metformin use at a dose between 1000 mg to 2550 mg daily, metformin cessation at the time of pregnancy test or menses unless the metformin therapy is otherwise indicated, and metformin side effects as described before. Ovarian stimulation for IVF in PCOS. Triggering final oocyte maturation with a gonadotropin releasing hormone agonist and freezing all suitable embryos would be considered in women with PCOS having an IVF or ICSI cycle with a GnRH antagonist protocol and at an increased risk of developing OHSS or where fresh embryo transfer is not planned. In IVF with or without ICSI cycles in women with PCOS, consideration needs to be given to an elective freeze of all embryos and individualization of controlled ovarian stimulation in IVF using ovarian reserve markers from theory to practice. Expected high response, expected normal response, and expected poor response. Main objective in high responders is to minimize OHSS risk and GnRH antagonist protocol plus minimal FSH stimulation. In normal response, the main objective maximize success rate with standard treatment. In poor response, main objective is to minimize treatment burden using GnRH antagonist protocol plus maximal FSH stimulation. Does freeze only increase the chance of pregnancy in high responders? Live birth is increased and OHSS is decreased. Role of myo-inositol in gut dysbiosis. So now coming to the dysbiosis, the pathophysiology, that is dogma theory, dysbiosis of gut microbiota. Diet rich in saturated fatty acids and sugars, which lead to growth of bad gram-negative bacteria in the gut, reduces bifidobacterium and lactobacillus. The cell wall of gram-negative bacteria is immunostimulant releasing lipopolysaccharide. Lipopolysaccharide enters systemic circulation. Innate immune system activation with release of cytokines and chronic low-grade inflammation in PCOS. Healthy gut versus leaky gut. If you look into the picture, you can see in a healthy gut there is normal intestinal permeability, that is the intact intestinal barrier. The intestinal content is colored upper layer, then comes a mucus layer with epithelial intestinal cells and lamina propria. This is homeostasis, that is the intact membrane. Coming to the leaky gut, there is increased intestinal permeability, damaged intestinal barrier. We see the two black arrows straight between the mucus cells. There is a leakage, undesired passage, that is pathogens, gluten, and casein. They lead to inflammation, translocation of intestinal contents, food sensitives, immune response. So the intact membrane is disturbed with increased permeability, leaky gut into the systemic circulation. Inflammatory markers in PCOS. Circulatory inflammatory markers in PCOS syndrome, PCOS, that is a systemic review and meta-analysis. The gut permeability along with metabolic endotoxemia with increase in cytokines like CRP, tumor necrosis factor and interleukin-6, they all lead to gut dysbiosis. Role of pro-inflammatory cytokines. Tumor necrosis factor alpha causes phosphorylation of insulin receptor protein leading to insulin resistance. In lean PCOS, the leaky gut causes increase in serum TNF and interleukin-6. TNF alpha and interleukin-6 have been linked to insulin resistance. Endotoxin lipopolysaccharide in the systemic circulation leads to increased fasting glucose, insulin levels, and resistance. Human studies have provided that good gut microbiota improves insulin sensitivity. Dogma, dysbiosis of gut microbiota. Increase in gut mucosal permeability leading to lipopolysaccharide from gram-negative bacteria, which enters in systemic circulation. The immune system is activated, which leads to induced chronic low-grade inflammation, which interferes with insulin receptor function, which leads to increased insulin resistance. And finally, there is increase in ovarian androgen production. Obesity and gut permeability. In obesity, the increased adipose tissue increases gut permeability. Visceral fat deposits increase cytokines, that is TNF alpha, and increased cytokines lead to reduction in anti-inflammatory protein, that is adiponectin. Chronic low-grade inflammation, that is PCOS. In the center of the chart, the chronic inflammation, it leads to poor oocyte quality and impaired ovulation in infertility with abnormal mitochondrial function and increased reactive oxygen species. And obesity, which is the prime factor, leads to PCOS, which is caused by lifestyle, and the lifestyle in turn leads to obesity. All are the factors leading to chronic inflammation. In the lifestyle, if you see the diet and physical activity, the diet has trans fats, animal protein, high glycemic index, lack of exercise or no physical activity. In obesity, increased adipocytes, increased leptin, increased free fatty acids, along with increased lipids, increased TNF alpha, CRP, increased WBC, that is leukocytosis, releasing increased cytokines, with increased insulin resistance, increased prostaglandins, and PCOS also leads to increased androgens. All this cumulative effect is chronic inflammation. Management of gut dysbiosis. PCOS management over the lifespan. Alpha-lactalbumin. If you see the this alpha-lactalbumin, that is, it rebalances gut dysbiosis and achieves eubiosis. This is the intestinal human enhancement of the epithelial barrier. If you see the green color, they are probiotics. They cause epithelial barrier enhancement. The pathogens are destroyed by mucins and defensins. And the second thing is production of anti-microorganism substances. The third is inhibition of pathogen adhesion. And the fourth is competitive exclusion of pathogenic microorganisms. These are the things done by the lactalbumin, with increased adhesion to intestinal mucosa, and in the lamina propria, there is modulation of the immune system, releasing interleukin 10 and TGF-beta, immature DC macrophages, they act releasing T helper cells 1, 2, and 17, which in turn the eubiosis is achieved with the alpha-lactalbumin, which acts mainly on the intestinal membrane. Coming to MI and alpha-lactalbumin improves MI absorption, that is peak plasma concentration of myoinositol with myoinositol plus alpha-lactalbumin and MI alone. If you look into the study, association with the alpha-lactalbumin significantly improves myointestinal absorption in vivo. So this definitely has a role in causing eubiosis. PCOS, a state of MI deficiency. If you look into the normal follicular fluid, it is rich in myoinositol, and the ratio of myoinositol to dechiroinositol is 100:1. The green rounds are M myoinositols, and the ovary is to the extreme left with capillary vessels, theca cells, and granulosa cells. And coming to the PCOS ovary, there are very less MI, that is 500-fold reduction in myoinositol. And the capillary vessels, theca vessels, granulosa cells, and the follicular fluid is very much deficient in MI. And the MI-DCI ratio is 0.2. PCOS with gut dysbiosis, that is MI plus alpha-lactalbumin clinical evidence. Effects of myoinositol plus alpha-lactalbumin in myoinositol resistant PCOS women. The study, maximized ovulation rate, that is 37 annualized women were treated with MI In that, only 23 ovulated, 14 no ovulation, and MI plus alpha-lactalbumin, total 35 ovulated with 95% ovulation rate. So definitely myo-inositol and alpha-lactalbumin has a good increase in the ovulation rate in PCOS patients. Reduction in hyperandrogenism. There is significant improvement in SHBG, that is testosterone level, free testosterone, dehydroepiandrosterone, and SHBG, with the MI, that is decrease in testosterone, free testosterone, and DHEA, and there is increased in SHBG, which in turn the combined effect is decreased androgens. Recommended MI plus ALC in PCOS. Levels of clinical evidence of MI plus DCI. There are 5 levels. Level 1, there is meta-analysis of homogeneous RCTs. Level 2 is meta-analysis of level 2 or heterogeneous. Level 1 evidence, prospective comparative study. Level 3, review of level 3 evidence with case control study and retrospective control cohort study. Level 4 is uncontrolled cohort studies with case series. Level 5 is expert opinion, case report, personal observation. So the highest level is level 1 with analysis of RCTs. Clinical evidence of MI in PCOS. A comparative study between myo-inositol and metformin in treatment of insulin-resistant women. Myo and met both reduced homo-insulin resistance, and there was no statistical difference between the groups. Myo-inositol administration positively affects hyperinsulinemia and hormonal parameters in overweight patients with PCOS. Effects of myo-inositol and D-chiro-inositol on hyperandrogenism and ovulation in women with PCOS, a systemic review. Myo-inositol and D-chiro-inositol appear to be effective in improving ovulation and reducing hyperandrogenism in women with PCOS. Coming to the pillars of MI-DCI treatment. Here, the dose, ratio, formulation, and compliance. If you look into the dose of MI, that is 4 grams per day is optimal for MI. And ratio MI and DCI optimal ratio need to be 40:1. And compliance, taste and acceptability by patients, which impacts efficacy. And formulation, micro-ionized granulation powder for better absorption and efficacy. Clinical evidence of international consensus. Experts have consensus that clinical data demonstrate efficacy of MI plus DCI in treatment of PCOD. These evidences are strongest for dose of 4 grams per day. This is an international study to find out the effect of MI and DCI, the link between metabolic syndrome and PCOS. So the dose which was efficient was 4 grams per day. Experts' opinion on inositols in treating polycystic ovary syndrome and non-insulin dependent diabetes mellitus, a further help for human reproduction and beyond. The combination of MI and alpha-lactalbumin was found effective in PCOS, and MI and alpha-LA safe at therapeutic doses. The US Food and Drug Administration included them in the list of recognized safe compounds. Conclusions. PCOS is a complex disorder with a complex etiology. Insulin resistance and hyperandrogenemia play an important role in the pathogenesis. Early diagnosis is key in addressing symptoms, improving quality of life, identifying fertility problems. Patient-centered approach with individualization of the management strategies. Lifestyle intervention improves quality of life. High responders freeze all improves clinical live birth rate. Counseling regarding the long-term complications of PCOS. Myo-inositols decrease insulin levels, glucose and insulin ratio, HOMA index. Myo-inositols decrease hormonal parameters, that is LH, and FSH ratio and testosterone hormone. Myo-inositol is able to induce normal menstrual cycles. Myo-inositol improves pregnancy rate compared to metformin. Myo-inositol effective in ovarian stimulation protocols in PCOS. Myo-inositol plus alpha-lactalbumin effective in gut dysbiosis associated with chronic low-grade inflammation in PCOS. Thank you one and all for your patient hearing.
Thank you so much, ma'am, for that wonderful session and delivery. Let me have a look at any queries are there from delegates. Just give me a minute, ma'am.
Yeah, sure.
Yeah. There is one query.
Okay.
So, in treating the PCOS, where would you rate myo-inositol along with the diet?
Myo-inositol comes under supplement. That is, follicular fluid in PCOS is known to have decreased myo-inositol. So we are giving what is deficient in the fluid along with the diet, because myo-inositols are present. If you look into that, they are in oranges, they say.
Yeah.
I think I only know that one, oranges.
Yes, ma'am.
Few nuts, they say they have inositols.
Yeah, even muskmelon also. Actually,
so if they are not taking properly fruits, it's better to take as a supplement.
Okay. Ma'am, another query. Can it completely replace metformin therapy? Myo-inositol can completely replace metformin therapy in PCOS?
PCOS I think they act as adjuvants, but metformin acts as a pharmacological agent.
Yes.
You can't get it in diet, or it's not deficient in our body.
Yeah.
But myo-inositol we are giving like what is deficient in our body.
Yes, ma'am. Yes, ma'am.
Not a treatment.
Thank you. So let me see if any other queries are there. It's fine, ma'am. There are actually no further queries. And once again, thank you for giving your time at this evening. And we are looking forward to have you with more and more webinars going forward.
Okay, thank you so much.
Yeah, thank you so much, ma'am. So I'm concluding the session, ma'am. I'm ending the session.
Sure.
Yeah.